Yes, so good morning, everyone. Once again, welcome back to Medical MCQ for All. As you know, we had excellent lecture of Ortho Rhumato once 3-4 days back. So those who have missed it, you can check it on our YouTube channel. I'll share the link very soon. Thank you very much once again. Those who are joining me first time, I'm very going quickly that we are the company. I mean, by Google statistic, if you check, this is top company nowadays with all your support and cooperation. So we provide almost everything. And two things we are going to announce today soon is one, we are launching the dental course, which is not in this list. So those who are preparing for dental exam or any middle list, and another is homeopath. So two courses we are launching very soon. Dental probably full fledged in 1 week of time. So if you have any concerns, you can directly approach me on this number or Pallavi. Right, she is also available. She is our support manager, so she will guide you. Those who are preparing for dental exam, just do let us know. Our QBank website coaching, everything is ready, but probably in max 1 week it would be ready to launch full fledged. So thank you very much once again for your these things. I'm Dr. Munjal, hemato-oncologist and bone marrow transplant fellow. As you most of know me, having a good deep academic interest. So I'm keep continuing my lectures every Sunday almost without failure for last many years. So I would happy to have you in my class 12 to 1:30 every Sunday same time. Dr. Arthi is our like backbone for gynec and pediatric. She's consultant pediatrician and gold medalist as well in my city only. Dr. Maddie again our one of the main and oldest coach for 5 years, right? Dr. Shikha is in Dubai, probably joining soon. She was there with our team, but due to something, right, she will again start things. And there are a lot of other doctors. This is Dr. Pooja, who is like a coordinator or main person for dental, Pallavi, and Dr. Sonal. As you know, she is delivering excellent emergency lectures, and lot more people are going to join soon. This is our hard copy book. We have, I mean, excellent discounted packages. We are revising now, so those who are really interested, they can get the advantage. Probably revised structure would be more little cost, less cost effective. So those who are genuinely interested, they can get the advantage of big discount things. Data flow we do. As I told you, we have lots of mock test modules. This is one more request from my side. Those who I recently couple of doctors also failed. We have 90% people who crack the exam in first go, but I know couple of people who drop me message. Personally, I could not crack it. I retrospectively reviewed, right? They are doing, I think so, less mock test. So mock test is the secret of success. Believe me, whatever I'm telling from my heart and my experience. So do maximum mock test and send me the score directly. If you send me score, I would be happy, right? But you need to know where you are standing exactly, where you are doing the mistake, what topics are weak for you, where you are lacking, what the missing in your preparation. Is there any change needs to be done in your preparation? Don't hesitate to discuss with me anytime. Just drop me message. We will discuss as soon as possible, right? As per your and my time convenient. But definitely, I would like to have you and guide you. No problem. So do maximum mock test from our website. And as I told you, I'm co-founder of EMREE as well, and dental we launched already, right? But probably in 1 week things would be ready. Heavy discounted packages are there, more than 60 to 65%. So 1000 USD package, including everything, coaching book, website, and other 10 things, just available in 350. So almost saving 600 plus USD. And one of the secret of success. One is mock test, second is a YouTube channel. The way I'm trying to deliver you, I'm just for your kind knowledge, I'm taking almost 100 USD per 1 hour for USMLE students. What I am delivering you now, absolutely free of cost, every Sunday without failure, right? So all the videos are available on this YouTube channel. The name of this channel is Medical MCQ for All. Secret of success. If you see one video per day, anytime 24/7, whenever you get free, Your 80% course is covered. While you are going to hospital, coming out of the hospital, you get audio, you get a headphone, you listen it. Almost your this one video is equivalent to 50 MCQ. So in 1 month, if you get to 20 video, almost by my sense, 1000 MCQ solved, and it is absolutely 100% concept based, no hurry, no nothing. The way we are delivering every Sunday, same exactly, and each and every MCQ video is just for your kind knowledge. It's different MCQ, no repetition, very rarely repetition. So all 1000 MCQs are different. So you can start from the latest one, say for example 16/11/2025. Today is the first video. Earlier video before that, last right 3 days video, say for example 2011 second. So start from the latest one, so you get the most of the crux of the all videos, right? So you get the most updated things. So without wasting the time, let's join and switch to the next question. I'm starting from my Q bank, the question number 10, because 9 we did it very well, excellently well. So those who missed, just go back last Sunday video. It's available on the YouTube channel. And let's start with the things. I would happy to join with me, answer any questions. Think that this question will 100% comes in your exam, so don't hesitate to interact. Right or wrong, don't hesitate,
बेबे
interact.
वो खोलो ना.
First question in front of your screen: which of the following is the investigation of the choice for evaluating suspected Perthes disease? A plain X-ray, ultrasound, computerized tomography, MRI, bone scan. Second question: how you differentiate Perthes disease from SCFE? What do you mean by SCFE? Sleep capital femoral epiphysis. One of the absolutely high yield questions asking every time in every exam. You can post your answer, and whenever you give me the answer, I will ask you only one question, and that is why. And we discuss each and everything, right? And we will differentiate one options from another in all MCQs. So one MCQ contains almost 8 10 questions, answers and questions and MCQ. So first of all, let's go to the basic MCQ. What is the diagnosis? So diagnosis, I think they had given Perthes disease, so we don't need to apply our lot of brain. How you supposed to investigate that? Probably they are asking, right? Suspected Perthes. What is the investigation of the choice amongst options given below? And obviously, I will ask the treatment as well. So if you ask yourself these three questions to yourself every day, every time, every MCQ, every patient in your OPD, your 99% job is done. So your time starts now. Try to be little faster in exam. You have hardly 100 seconds for a one MCQ. So if you are not speed up, you are gone. I'm not trying to scare you or disappoint you, but it is fact, right? So you need to be very smart. And smartness will come from the experience and practice. Yes, Aniba. So what do you think? What is the answer? Only one questions, right? So those who shy to answer, just I mean in general, right? You can post your answer in the chat box. We have a facility of chat box, so you can answer your these things in chat box. Yes, please. Yes, Aniba. Why you want to do
Emer-
MRI? Why you don't want to do the X-ray? Yes, you can unmute your mic. Your answer, Dr. Shaniba, is MRI. So my question is why you don't want to start with the plain accident? It's a easily available everywhere, cost effective, cheap. By knowing the X-ray, you can diagnose many things. So why you do want to do a lot of money, wasting money on MRI, and like MRI is probably not available everywhere. Why you want to do MRI? Why not X-ray? Yes, yes, Dr. Indu, what's your comment?
Mhm. Maybe X-rays are
Yes,
the initial investigation of choice, maybe, sir.
sorry, initial investigation is what?
X for this Perthes disease, X-ray is the initial investigation, maybe like, but
And
here the
so
investigation of choice, like,
Fine.
Yeah,
So
so
let me dissect this question. Initial investigation would be different from the based investigation. Another question they ask you, what is the highest sensitive and specific? Sensitive and specific could be different. So you need to understand, right? Differential diagnosis is different, diagnosis is different, confirmatory diagnosis is different. These are the all small words, right? But it makes huge impact on your answer. So you need to understand. So what is your answer, Dr. Indu? Right? Reading these questions, what you supposed to think that this could be the answer and why? If your answer is X-ray, then I'm asking you why not MRI. If your answer is MRI, then I'm saying why not X-ray.
okay.
You need
So
to know.
X-ray will be the initial investigation of choice.
Wonderful. So it's an initial investigation of choice, right? So they are
Mm.
asking following which of the following is the investigation of choice for evaluation of suspected Perthes disease. So now what's the answer?
Uh,
Sir, X-ray would be the answer because MRI can, if you want more accurate diagnosis, MRI would be the
So I
choice.
think this question is saying the accurate, na?
Okay.
Investigation of choice, right? So if
Mhm.
you have one thing you have to pick up from this list, what you
So
supposed
then
to
it
pick up?
will
That
be
is,
MRI, sir.
yeah. So your answer would be wrong, na? When you are posting in exam, you are posting the answer M X-ray, right? Then it could be little controversial, right? Because
Mhm.
as I told you, let me give you one clear-cut, brilliant example of my subject, like say for hematology, right? So you get the idea, right? This is where most of the doctors are doing the mistake. So say for example, I'm suspecting one patient, right? Patient has a pancytopenia, right? Patient has a pancytopenia means low HB, low WBC, low platelet count. That is called pancytopenia. Four different answer. If they ask, what is the most initial test for diagnosing acute leukemia? You are suspecting this patient as acute leukemia, whether AML, ALL, forget. So, what is the initial investigation? Then my initial investigation answer is CBC and peripheral smear. Without that, how you supposed to know, right, that this is leukemia or not leukemia, right? If the
Mhm.
CBC is normal, then there is no meaning of suspecting leukemia. So when patient
Mhm.
comes, right, you are suspecting some leukemia, right? 5 years of boy, child with lymphadenopathy, with headache, right? With splenomegaly, you are suspecting ALL, right? You did not did any
Mhm.
blood test. You are suspecting on the clinical base or ground or clinical vicinity. This could be ALL because more common in children. Lymphocytosis is there, lymphadenopathy is there, hepatosplenomegaly is there, and everything is there in this boy. You are suspecting ALL. First initial investigation is CBC and peripheral smear. In CBC, likely you see pancytopenia, and peripherals you may or may not see blast cell. This is initial. Now they say how you diagnose now. You did this, and in CBC you have pancytopenia, you have some blast cell, look like, right, or atypical or blast looking cell. You did a diagnostic test is bone marrow. In bone marrow, you find that it is likely ALL, right? All lymphoblast you can see, right? And there is a lymphoblast you see. Third question is, what is the most confirmatory test for acute lymphoblastic leukemia? The answer is immunophenotyping or flow cytometry. They are asking in apps, then confirm ALL patient, which is the one of the most prognostic test for acute lymphoblastic leukemia, which says you this patient will survive 1 year, 2 year, 5 year. That is called prognosis, and test is cytogenetic or FISH test or NGS, next generation sequencing, the new test. So see the one scenario, four different answer. Initial CBC peripheral smear, diagnostic bone marrow, confirmatory immunophenotyping, prognostic cytogenetic FISH. Try to do this practice for each and every acute myocardial infarction. Ask yourself, what is initial test, what is diagnostic, what is confirmatory, what is prognostic. They are asking you, say for example, stroke patient. So stroke patient, what is the initial test, what is the diagnostic test, confirmatory test, prognostic test, blah blah. Each take any, say for example, tuberculosis. Ask for questions too. What is the initial, what is the diagnostic? So this is how you learn the medicine. I am not here to mug up the things and passing the time. I am in the sincere academic things. I'm a absolutely sincere coach. I want you to learn the medicine, forget about exam. Even if you crack, well and good. If you don't crack, my tips and trick will 200% will help you to save the life of the patient in the clinic. That is more important than the just simple exam. You can pass in one attempt, two attempt, that's fine. But if you miss the critical things, you probably not being a good clinician. I want you to be a good clinician. Is that clear? So let's see and dissect what is the answer here. The answer is magnetic resonance imaging. Perthes disease, or another name is Lake of Perthes disease, shortly known as a Perthes disease. These are the three gentlemen, Mr. Lake, Mr. Kav, Miss Perthes, but this is a Perthes disease. What is exactly? If you don't know what is Perthes disease, I'll let you know.
हेलो.
It is avascular necrosis
हाँ
of the
जो मैंने
femoral head in
मतलब आपको इसलिए
children,
बोल के तो फोन किया
usually
टेट की ड्यूटी
between
कब
4
तक
to
आ
8
सकता हूँ
years
आपको.
of age. Yeah. Let me mute the mic because I'm disturbing by someone in the background. So if you are not interacting, please make your mic mute, then unmute if you want to discuss. So Perthes disease is avascular necrosis of the femoral head in children. Now let's see. We have a 4 5 options in this: X-ray, CT scan, MRI, blah blah. Plain X-ray. Why it is not the answer? Plain X-ray. Or right findings utility early. Maybe normal. In early stage it could be normal. So you may not get the idea. Right. So very advanced stage you can get it. What they are saying? Investigation of choice. Choice means you have all the best of the best choice. All the best of the best choice. They are not saying patient is poor, minimal, less costly investigation, please advise, then X-ray. They are not saying it patient is poor and they have no money. Best investigation of choice, acute myocardial infarction, right? AMI, investigation of choice, coronary artery disease. Early stage ECG could be normal, right? Within 4 hours, TROP-T, TROP-I, CKM be normal. If patient comes within 15 minutes of chest pain, everything is normal. Drop T, drop ICK, everything is normal. They need some 1 hour, 1.5 hour to get the right plasma level to be detectable in the plasma. So likewise, you need to know the thing. So X-ray not helpful much, right? Until and unless it is very advanced stage, right? Ultrasound non-specific, not helpful. CT scan, what is the difference? Shows bony architecture, it shows bony architecture. CT scan, not the vascular, not the vascular. And Perthes disease is a vascular disease. It is a vascular necrosis, it is not a vascular bony disease. There it is not a bony disease because of a vascular necrosis. Vascular means vessel. You need to see some vessels very nicely in a magnified way. So MRI is absolutely better than CT scan. So CT scan cannot see vasculature. Somebody, if you are suspecting something, aneurysm in the brain, if you have two options, CT versus MRI, go for MRI. Ultrasound is not, it is until and unless late stage. Bone scan at all not helpful, sensitive but less specific than MRI. So MRI is the investigations of choice for Perthes disease. So that's all for Perthes disease. In terms of investigation, I need one volunteer who can differentiate me head to head between Perthes disease and the questions, right? What is the second question? How you differentiate Perthes disease from sleep capital femoral epiphysis. So what you want to know or what you need to tell me, right? So this is Perthes disease and this is slip capital femoral epiphysis. What is the age in between, right? What is the age here? What is age here? What is pathology here? What is pathology here? How the clinical presentation here? How the clinical? What is the investigation of choice here? Here. What is the treatment here? What is the treatment here? Anyone now? High yield question. We did hundreds times this Parthis and all, but we never probably think in that way, the way I'm telling you now. So you need to think because they may, I'm teaching you now Perthes disease. They may ask you sleep capital femoral epiphysis. Can anyone tell me same options, right? Can anyone tell me all four same option? I'm removing here and I'm putting here sleep capital femoral epiphysis. What is which of the following is the investigation of choice for evaluation of suspected SEFE disease? Now, what's your answer? Second question in one equation. Yes, please. They probably not ask me the way I am only teaching you the MCQ. They can ask you anything in exam. So you need to apply your brain. Yes, Saleha. Any comment, Dr. Saleha, Deepika? Yes, you can post no idea in chat box. No problem. Probably today's my class is bit difficult.
Sorry, sir, I didn't get your question.
My question is that you have a question, which of the following is the investigation of choice for evaluation of suspected slipped capital femoral epiphysis? This is what the thing is given here. The original question was Perthes disease, but now I am changing my question. Perthes is gone. Now it is slip capital femoral epiphysis. If this is the question in exam, how you suppose? Options are same. Plain X-ray, ultrasound, computerized, MRI, bone scan, or something else if you want to comment, which is not in the option. Something else. Did you get my question? Yes or no? Or would you like me to
Yes.
Yes,
repeat
yes.
again?
No, sir.
No, no.
Wonderful, brilliant. Take your time. We are not in hurry. Absolutely learning platform. If we sort out two question list, fine. Whatever you do the best forever, permanent. This all will come in exam. Probably you'll remember me in exam room. Yes, please.
The investigation of choice uh, for
Yes,
Perthes
please.
disease, we just now discussed that it is MRI.
This disease we discussed MRI. So do you feel that SCFE is the same? MRI is also the same answer or it's different answer? You got the question, right?
Yes, yes. To differentiate,
Wonderful.
we need an MRI.
Is it
So
For slip
X-ray, sir?
capital.
forget about Perthes
X-ray, sir.
now. Perfect
Is it
about
X-ray,
Perthes
sir?
now. Yeah, I'll got your answer, Dr. Deepika. Your answer is X-ray, right? Let me ask Madam Saleha what she is thinking. Which of the following is the investigation of choice for evaluation of suspected SCFE means slip capital femoral epiphysis? Forget about Perthes now at all. Yes,
The
please.
first investigation we would like to do would be X-ray, definitely. And
The
to
same
confirm the
question,
diagnosis,
investigation.
MRI.
Yeah. So what I'll keep your answer for this question? I keep X-ray or MRI for you. If same question comes in your exam, you have liberty to tick only one option, not the two option. What will you took? A or D? A is X-ray, D is MRI. What you would like to go? I'm just trying to understand your concept. And why?
MRI.
Obviously, why? MRI. So your answer is MRI. We'll see the correct answer. Don't worry. So your answer is MRI. Anyone else want to? Induja, Savita, Deepika, anyone wants to comment here on these things? We are joining more than 25 doctors now. Dr. Sama, Khadija, Chris, Susan, Sandhya, Anisha, Lalit, Nisalal, PB.
Sir,
Anyone can
investigation of
comment.
choice for slipped capital femoral hypophysis is plain X-ray only, sir.
Yeah,
Wonderful. So
plain
why not MRI? Why not MRI? Why
Sir,
not MRI?
Because we
we
only
are
have
not going for any vessels now, sir. It's just only the bone. So
Wonderful.
initially, because in
So
bone is
Perthes
so
best
disease, it's
visualized on
vascular
an
necrosis.
X-ray, sir.
Huh.
okay, fine. So let's go to the basic. Perthes disease and slip capital femoral epiphysis. It is a avascular necrosis. So it's a vascular disease. Is it vascular disease or non-vascular disease?
Non-vascular disease, sir.
Non-vascular.
Non-vascular disease. So MRI is not needed probably, right? Because it's
Yes.
non-vascular. It is not needed, right? So Dr. Saleha, are you getting me? Right? Because probably something
yes.
going wrong, probably in terms of how it develops. That is why the answer was wrong, right? So it is not an MRI, it's an X-ray. So let me see why X-ray, why not MRI, right? Anyone wants to? So now this is, I mean, whatever my slides, 99% will not get in any Harrison, Davidson, blah blah, any books because I do some research on my. I'm trying to make the PowerPoint, my PowerPoint most easiest understandable way, so I have a lot of journals subscribed, so I getting some pictures and blogs and slides from there only. So MRI is the investigation of choice for detection, early evaluation of Perthes disease. It can detect the bone marrow edema and loss of the blood supply before radiological signs appears on X-ray. So for Perthes disease, right, early you can detect in early stage MRI, right? Once you have all confirm and diagnose, okay, fine, this is Perthes disease. Every time you don't need to do MRI. In established case or follow-up case, X-ray is good enough. X-ray is good enough. But investigation of choice is MRI. Let's see for slip femoral capital epiphysis. Now see the difference. Let me show you the difference. Exactly head-to-head difference, which will brings lots of clarity to our mind. What is Perthes and what is this and what is that, right? Which we trying to avoid every time to read this topic, right? That is why I took only topics which is toxic. Perthes disease and slip capital femoral epiphysis head-to-head comparison. Absolutely transparent. It is idiopathic. A vascular necrosis. Vascular necrosis you cannot see on X-ray, on CT scan or ECG. That is why MRI is investigation of choice. And this is not a disease of vessel. It is not a avascular necrosis, Dr. Saleh. Are you getting me? It is a displacement,
Yes, yes.
right? Or slip. The name itself, slip. What slip? Femoral head is slipped, right? Where it slip? Posteriorly and inferiorly. Which part of the neck, right? Femoral neck. So femoral neck is somewhere slipped, and because of that patient has a symptoms, right? So this is not avascular necrosis. It is a displacement or slip, and that is how the name comes. The first word is slipped capital femoral epiphysis. So something related with the femoral head, right? So displacement of femoral head, right? So this is the pathology, simple, nothing to do with the vessel. And that is why MRI is not the answer, because we don't need to go and check the vessel. We are just trying to see it is because of sleep, something mechanical. Age group is bit early. Shortly, if you want to remember, less than 10 years. And if you want to remember more than 10 years, simple way. So this is second differential. So age is extremely important. If they say 5 year of old boy presented with the unilateral pain, limping, hip joint, blah blah, likely Perthes. Why? Because this is usually after 10. This is 5 years. So age is extremely important. Sex epidemiology. Age is less than 10. Here more than 10. Sex, right? This is boys more than girls, here boys more than girls, but here the its Perthes is more, I mean incidence is more. Body type, how is the patient's morphology? Look and feel. Patient's look and feel. Patient is thin and active. Here patient is obese or tall and adolescent, right? Here thin and active. So this all will come. 5 years of thin boy presented with unilateral pain, right? This. So 5 years age matching, unilateral matching, thin boy matching. So all goes in favor of Perthes. So each and everything will be given to you in exam. Believe me, there is no absolutely confusing scenario. Who confused? Ourself is confused. We are confusing ourselves, not the exam, not the MCQ, not the DHA, HAD, MOH, because our concepts are not clear. So it is absolutely unilateral. You never ever get at the same time bilateral avascular necrosis, unilateral. This is bilateral in up to 50% of the cases. So somebody say bilateral pain. Bilateral pain means like it is always unilateral. So until proved bilateral pain, 10 years of boy presented with this, right? Then it is a SEFE. That's it. All matching. This all each and every line will help you to differentiate. Etiology, temporary, not permanent, temporary interruption of the blood supply to the femoral head, and necrosis, that is avascular necrosis. Here no necrosis, no avascular necrosis, mechanical stress, not a vascular thing, and plus weakened epiphysis, right? That's it. So this is the pathology. So this is one comparison. Let me go little forward and move my clock little forward. Each and everything is important. So we have seen unilateral, bilateral, age, body type, side affected, etiology, and let's see the Perthes and SCFE, right? So these are the all other differentiating point. This is Perthes disease, slipped femoral, capital femoral epiphysis. Pathology, avascular necrosis. Now we know very much clear cut. This is a mechanical. It is a slip of the femoral. This onset insidious onset, often gradual limping and pain. This is acute or chronic. Maybe suddenly after minor trauma to the hip. Pain location hip, referred to knee and thigh. Hip referred to knee and thigh, almost same distribution. So you cannot differentiate, but there are a lot of differentiating point. Hip involvement, movement limitation, loss of abduction and internal rotation, loss of internal rotation, abduction and flexion, right? And leg is oftenly externally rotated, internal rotation is lost. So, and if at all you do, it's a very much painful. Leg position may slow slight shortening, avascular necrosis. Bone is gone, bone is distorted. So it's a shortening, right? So here usually not a shortening. Limb appears externally rotated, may be shortened. X-ray finding flattened or fragmental femoral head, widening joint space, sclerosis. Here posterior inferior displacement of the head, ice cream slipping of the cone. Ice cream. So this is ice cream. Na? We eat the cone. This is cone, right? This is cone. Ice cream in cone, right? I love it, right? So this is gone. This is displaced, right? So posterior inferior displacement of the femoral head, and this is a joint. So it's a displacement. So you can see clear cut, right? So that's it. And here activity restriction, and here probably the surgery, that is a treatment, right? So this is absolutely called head to head comparison between these two. So you can't afford to miss this all high yield points which is not given in the book. So either you can take a picture. I would be happy if you can take picture. I don't mind if you want to take picture later on from our YouTube channel. All will be uploaded in next 2 hours. So that's it. This is the crux. This is the treatment. So this is the Perthes disease. So Perthes disease is what? X-ray, fragmentation and flattening. If you do the here the ice cream slipping of the cone. Femoral head mechanically got posteriorly displayed. Less than 6 years, you can probably do conservative treatment. More than 6 years or severe cases, surgical, right? That's it. And this is urgent. It is slipped. It will not come back, right? It will not come back to the position by any medicine. So here absolutely surgical. Weight bearing restricted depending on stage, right? Restricted, non weight bearing until fixed. Absolutely you can know. Otherwise osteoarthritis, fracture, lot of complication will occur. Complication, femoral head deformities, early osteoarthritis, avascular necrosis, chondrolysis early. Eventually, this does. Perthes, last but not the least, the what is the mnemonic? Perthes means poor blood supply. This is slipped epiphysis. This is vascular problem. This is mechanical problem. Here, reduce the blood supply to the head of the femur. Here, the head of the femur is slipped, right? So here, so this can be easily picked up by X-ray because you can see now, okay, fine, head of the femur is displaced. This is X-ray. X-ray shows nothing. Here, investigation is MRI. Dr. Saleha, if I'm not wrong, you got the crux of the talk, right?
Yes, I did. There's one question, like if you
Yes,
could
please.
just uh,
Please
tell me
ask.
the when the question is asking investigation of choice.
Investigation of
So,
choice means try to use the best investigation amongst the list. That's it.
okay. So when we are confirmed on X-ray that this is slipped capital epiphysis, so we will just proceed for the surgery, or we still like to do any other investigation to confirm before proceeding?
Once see X-ray in any case, it's a initial test. Simple, right? But when you
Okay.
can suspect this from the X-ray, you don't need to do the high five. Now, say for example, severity
Mm.
of the sleep capital femoral epiphysis, right? More things. Then you can probably do more CT scan for the bone, right? Vessel, nerve, and neurological system whenever involved. Say, for example, head, spine, spinal cord, nerves, peripheral nerves, cranial nerves, means CNS. Whenever CNS is involved, try to do MRI.
Okay.
You got it.
As the initial investigation, you mean?
Initial investigation means
Suspected,
the,
for suspected.
once again, let me clarify. I'm not in hurry. Whenever they are asking you investigation of choice, if this question is comes, you have many options, right? Many options in your exam. So investigation of choice means the test which is most close to the diagnosis or which confirms the diagnosis or which is the choice from the list, right? X-ray probably you
Yeah.
may or we you know you may not see, right? Then you need to do the MRI for just for example, right? But
Yes,
X-ray
yes.
will give you the clear cut idea. Then it is investigation of the choice, right? So this
Right.
investigation of choice could be different from Perthes. This is because it's depend on the etiology, right? It depends on the etiology, right? So chest
Yeah.
pain, every chest pain does not need angiography. You need to first have suspicious of angiography. If chest pain is, say for example, you know that in 2D echo there is a severe mitral stenosis. So for severe mitral stenosis, if we are suspecting, then go for echo, not the angiography, right? On
Right.
if you think that this is congestive cardiac failure, then go for echo, not for the angiography. So depends on what you suspect, what could be the best investigation, initial or investigation of the choice. You need to do little practice. So for the to answer this, my experience for last 20 years in clinical practice, look at the pathology. What is the pathology? What causes this? Right? What causes this? Right? If chest pain, you are suspecting pulmonary embolism, go for CT pulmonary angiogram. You understand, right? In that case, you don't need to
Yes, yes.
do coronary angiography. You are suspecting pulmonary angiogram. You are suspecting, say, esophageal rupture in a chest pain. There are a lot of cures. So you do accordingly. So depends on what you are thinking for the patient, that will probably make you to reach up to the perfect diagnosis. Like here, see, the etiology was different, and and this is where we did a mistake. Or most of, even I can make a mistake that okay, MRI is the best, do MRI, both the things, sleep capital femoral epiphysis or Perthes, MRI for both. But it is not the same for both, because one is a vascular problem, one is mechanical or some other problem. So depends on the problem. You need to judge and answer the disease. Is that clear to you? Right? So,
Yes, yes, yes.
for
Very
ending
much.
up the talk for this is the key take home message. If you don't remember anything, just 4 line will be good enough to differentiate Perthes versus sleep capital femoral epiphysis. Perthes usually in the child less than 10. This is 10 plus adolescents. This is take home message. Perthes disease, patients are usually thin. This is obese. Mechanism, Perthes is avascular necrosis. This is mechanical sleep. Imaging, MRI is the best. X-ray is the diagnostic. And management, Perthes conservative in small kids or osteotomy, right? And here, urgent surgical fixation. So that is the bottom of the talk. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir. Yes, sir.
Yes,
Wonderful,
sir.
wonderful. So try to understand. We don't need to mug up any questions. So this is the things what I already explained and told you. So not going much in detail. Let's jump to the another questions. 45-year-old old, right, was given steroid, right? So let me tell male or female. So 45-year-old woman presented to you who has received steroid after renal transplantation. After 2 years, he or she had difficulty in walking and pain in both hips. Which of the following is most likely diagnosis or cause? Primary osteoarthritis, avascular necrosis, tuberculosis, osteoarthritis. What is the diagnosis? How you exclude all other options? If your answer is A, I am asking you why not B? If you answer B, I will ask why not A, C, D, blah, blah, blah. So take your own time. Everything is, if you have a cultivate to read the questions brilliantly, 99% of the answer you will get without seeing the options. If you do not see the options, you can get the answer. When you read this well. So spend by my experience. So you have 100 seconds in exam for one MCQ. My advice by experience is that spend 98 seconds in reading questions, 2 seconds on this, and 1 second and click ABCD, tick, go to second question. But unfortunately, we are not doing this. We are trying to be in so much of hurry to answer without reading the questions where there is a high probability and possibility you end up with the wrong answer. Why? Because you did not understood the question. How you supposed to answer? Read it well. I am not in hurry. Forget about option. You can give answer without options. Believe me. Every question is not difficult. Yes, Lalit. Welcome back to our platform. You are lost earlier. Yes, Lalit. What is the answer? Your answer is A or B or C or D or anyone. Out of 30 doctors in the group, we just got one or two comment in the chat box. So, Dr. Rabia Bibi, can you little guide? I mean, what's going on with this patient? How you answer or what you are thinking? What's the diagnosis? So 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 secret of
Yeah,
success is the
hello,
triad. Believe
hello,
me.
hello, sir. I'm unable to write on chat box. I don't know how
No,
to
you can
write.
speak now. No. I'll teach you one to one later on. You can speak it meanwhile. What is the diagnosis in this patient?
It should be primary osteoarthritis.
Primary osteoarthritis. Okay,
Yeah.
fair enough. So, what are the point favor in this for osteoarthritis? Tell me one by one. Sir, this point is in favor of osteoarthritis.
The age of the patient,
Age of the patient is here they are saying
35.
he means male patient. So little
Oh,
45 is
he.
bit early age for patients. But anyway, okay, age. What else? What
And
is the relation?
honesty,
What is the relation of steroid? What is the relation of renal transplant? Right? And do you think osteoarthritis is a bilateral? By my knowledge, osteoarthritis is usually unilateral. Rheumatoid arthritis is bilateral. By my general knowledge, probably I'm right. So it is a
yeah.
bilateral. Rheumatoid arthritis, osteoarthritis is usually unilateral. Usually unilateral, like osteoarthritis of the knee joint, osteoarthritis of the hip joint, blah blah blah. We see a lot of discussion on this lectures only, right? Why there is a is there this is steroid causing osteoarthritis? Can steroid cause osteoarthritis? Because they are
Mm.
saying that this patient, right, this much old, right, given steroid, right, so he is on steroid for 2 years. Why he has received that steroid? Because patient has a renal transplant, so there is a drug which are routinely given to prevent the rejection of the graft. So father has
Yes.
given the kidney to his son, say for example. So son
Mm.
got the kidney from the father. So son is renal transplanted at 45 years of age to avoid the rejection or graft versus host disease, right, which is a complication of allogenic transplant, right? They are receiving the steroid, right? So do you think this 2 years of steroid will develop osteoarthritis? And that is also
Sir, this
unilateral. Why not
uh,
bilateral?
sir, actually, this 2 years of steroid will cause osteoporosis instead of osteoarthritis, sir.
Okay, so your answer is osteoporosis.
Yes, sir.
Okay, but it is not in the list. So what you want to
Okay.
select?
Yeah, so avascular necrosis will be
Breast
the
fibrosis.
appropriate answer, sir.
Fine. So why the avascular necrosis? Why not the osteoarthritis? Dr. Rabia is saying that this is primary osteoarthritis. Why then it is not? Why not it is primary osteoarthritis? Discuss. Let's discuss because
Mm.
discussion brings the clarity. not just reading the question. Yes, tell me.
Hmm.
Sir, because long-term steroids can patient put on weight, sir. Patient might put on weight and uh, maybe hypertension or diabetes might increase and osteoporosis, and that might lead to necrosis.
So what is the answer? Sorry, Savita, what is your answer? Final answer, tell me. A, B, C, or D?
No, because osteoporosis is not in the option, so vascular necrosis because muscle weakness will be there.
Let me add. Okay, just to avoid osteoporosis.
Uh,
This is confusing. This is confusing little bit, right? Osteoporosis, right? Remove this. Now, what's the answer? Not very difficult question. In exam, this is two-liner question. In exam, there are 10-liner question. Don't get scared. I'm just trying to make you mix the concept. So, what is the final answer? Anyone? Dr. Anisha, have you ever come across such a type of patient? Patient is on renal transplant, 2 years of
Yes, sir.
steroid, and now present with the bilateral hip pain.
Yes, sir. This is the case of avascular necrosis because patient has did this renal transplantation, and she was on the systemic steroid for a long time, like 2 years, and that is the major risk factor for the avascular
Wonderful.
necrosis.
Now let's enumerate the list of steroid side effect. Those who did not know side effect or adverse event of steroid, 100% go open up the book and read. This is one. Every patient is on steroid sooner or later, right? Either in ICU they are giving hydrocortisone or dexamethasone or anaphylaxis or bronchial asthma or skin disorder. Steroid is there in the picture. So each and everybody need to know the side effect of steroid, simplest side effect of steroid, commonest side effect of steroid, dangerous side effect of steroid. Dangerous. So just give me the dangerous side effect of steroid. So say for example, somebody is taking 2 years of steroid continuously. What are the dangerous? Forget about simple. He will not die. Common, he will not die. Dangerous, he will die. Tell me. Open for all. It's important, na?
Immunocompromised. The patient
Immunocompromise.
will be
Let's say
immunocompromised.
immunocompromise is not the side effect. It rather reduces the immunity, right?
Immunity.
Which makes them immunocompromised, which makes them more susceptible to
Oh,
infection or
oh,
opportunistic infection. Isn't it? That
Mm-hmm.
is what you mean to say, right? If I'm not wrong.
Yes, sir. Yes, sir.
Wonderful. So this is one. There are 10 side effects.
Uncontrolled, uncontrolled blood sugars.
It can increase the blood sugar. So it is difficult to give it in diabetic. Somebody who is already on insulin, having a 400 sugar all the time, and now you are starting the steroid. So it's difficult. Isn't it? Yes or no? Third,
Yes, sir.
I need to know at least 10 side effects. We reached at third step. I need 10. Open for all. I am
Yes.
not
There
asking
is
you
weight
very
gain.
difficult. Weight gain is not dangerous in short term, but yes, obesity, right? In other word, I can put the better fancy word is a Cushing syndrome. If you agree with me,
Yes.
Cushing syndrome,
Yes, sir.
it is one of the
Yes.
most commonest cause of iatrogenic hypercortisolism or Cushing syndrome. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Wonderful, brilliant. What else? So if you don't know 1 to 10, go and read. Tell me tomorrow, post me personally. This is my number. Those who put me the answer, I would feel that they are respecting me. Send me direct message on this number that these are the 10 deadliest side effects. Probably our family, our father, our mother, our friend, our patients are taking this. We don't want them to die because of steroid, not because of disease. So their disease is fine, but because of side effect of steroid, they died. Is that clear, everyone? So you need to know one of them is avascular necrosis. So now let's dissect all the options as usual. Our trend. So most likely diagnosis is avascular necrosis. Why we dissect? If somebody does not agree with me, discuss again. So first listen me. A 45-year-old man received steroid after renal transplant. After 2 years, developed difficulty in walking and bilateral hip pain. This is a clinical picture of classical for steroid-induced avascular necrosis of the femoral head. Steroids are one of the strongest and best non-risk factor for avascular necrosis, which this patient is already receiving post-renal transplant. Why it is avascular necrosis, and we'll see in the next slide why it is not other options. So here clue, what are the clue? History of chronic steroid use, which is strong association with avascular necrosis. Renal transplantation, often a long-term immunosuppressant, including steroid. Bilateral hip pain, AVN commonly affect with bilateral hip pain. Gradual progression over the years, it is again a typical for avascular, not the sudden, right? So these are the point favoring. Which points are not favoring? That is also important. Somebody is asking, sir, why not other options are favoring? Let's discuss other options. Okay, fine. Let's discuss other options. How to exclude other options? Primary osteoarthritis. Why not? Here we are discussing why not. Why not primary osteoarthritis? Avascular necrosis, we discuss. We discuss what point favoring AVN. Now discussing why not primary. Osteoarthritis is age related, usually after 50, more commonly in elderly, not at 45. Our patient is 45. O is commonly, not commonly bilateral, right? Right? Severe so quickly, right? So our patient has a bilateral. Osteoarthritis is usually unilateral, right? 45 osteoarthritis usually don't develop, usually after 50, 55 postmenopausal, right? Osteoarthritis usually no major risk factor. It's an aging process. Have you heard the word wearing and tearing of joint? Yes or no? Yes or no? It's a degenerative joint disease. Yes or no? At least tell me yes or no.
Yes, sir.
Right?
Yes, sir.
So steroid has nothing to do with the osteoarthritis. Whether I'm taking myself, Dr. Munjal, not taking when I turned up 50, 55, 60, without steroid, even for single day, I will develop osteoarthritis. Any female after 45 or 50 without anything, she will develop menopause. Is that clear? It's a aging process. Osteoarthritis is an aging process. It has no risk factor except age, right? And here strong history of 2 years of steroid, which is not there. Would show joint space narrowing, right? Osteoarthritis, which is not mentioned here. So compiling all the things, osteoarthritis is not the answer. Anyone has any confusion, not agreed
No,
with
sir.
this explanation, we can discuss further.
No,
If you agreed,
no,
I'll
sir.
go ahead.
All is clear. All is
Wonderful.
clear.
Tuberculosis excluded. Why not tuberculosis? Let's discuss. TB of the hip joint. It could be possible. TB of the hip joint, immunocompromised, any infection can develop. Why not TB? So TB of the hip is slow progressing, typically includes constitutional symptoms. So TB won't come directly with the hip joint pain. He may have fever, he may have night sweat, he may have cough, he may have weight loss. Nothing is there. Are you getting me? Yes or no? Right? Often
Yes, sir.
unilateral. Tuberculosis not developed within 1 day or 2 days in bilateral. Our patient has a bilateral hip pain, avascular necrosis, bilateral. No TB exposure in the history. Immunosuppression increases, but the bilateral hip involvement favors AVN, avascular necrosis. So hopefully you are agreed with my all explanation that why this, not why this. Let's discuss, right? And last but not the least, osteomyelitis is also in the option. So we have osteoarthritis primary, we have tuberculosis, we have osteomyelitis and AVN. So we excluded two things. TB we excluded. Osteoarthritis excluded. Why not? So patient has a fever, patient has a pain, patient has so osteomyelitis. Myelitis. Osteo means bone, myelitis means inflammation, and signs of inflammation is pain, fever, loss of functions, elevated markers. Osteomyelitis is never ever developed bilaterally. I never seen it. It is unilaterally. Our patient is saying bilateral pain and a 2 years gradual progression to chronic of osteomyelitis. So if you get any infection, systemic infection within 1 year, 1 month, 2 month, 3 month, 4 month, today you get infection, after 2 years you get bilateral hip pain is extremely less likely in osteomyelitis. That is what they want to convey. So concluding the all crux talk and talk tips, final diagnosis is avascular necrosis of both hip joint secondary to steroid. Any question?
No,
Any
sir.
question? All clear?
Yes,
Wonderful.
sir.
Jump to the
Yeah.
Yes.
no question from audience means I will go ahead. If questions stop me, don't hesitate to stop me. Little tricky question, check your real strong pharmacology. So if you correct this answer, consider you have good pharmacology knowledge.
Mhm.
Each agent which decreases the bone resorption in osteoporosis are all except, read it again, agent which decreases the bone resorption in osteoporosis are all except res, residronate, teriparatide, strontium ranelate, raloxifene. I would like to know all what all four drugs is meant for. And without jumping the question, I would like to know what is bone resorption. Just fundamental things, right? Because in the options, they have used one word, fancy word, bone resorption. So first of all, I would like to understand what is the definition of bone resorption, right? There are a lot of things, definition of bond resorption, in which the bond resorption increase, which drug reduce the bond resorption, what are the condition where you see the bond resorption, right? What is the drug of choice to reduce the bond resorption, blah blah blah. 100 things are there. But before that, all complex things, I want to know only one thing, definition of what is the bond resorption, because we read thousands of time in our book and all, but we probably may not know. So I am touching all the sensitive point of our knowledge. Don't take it otherwise. Yes, anyone, open for all. We are 25, 30 people are in the group who can answer this very nicely. So it is a simple concept. What is a bond resorption? Anybody wants to try, they can try before answering the question. Yes.
It is the part of remodeling.
Okay, part of remodeling. Okay, so I'll write down your word part of remodeling. What do you mean by remodeling? What happens to the bone in remodeling? I'll
Sir,
give you some
calcium is
examples,
Basically,
sir. This is
absorbed
an
into
example of, sorry. Yeah, go ahead. I'm
Break
calcium.
down
listening.
the bone tissue, like
Sorry, Dr.
excessive bone
Deepika.
tissue or whatever we don't want. Like we break down the
So,
bone tissue, like osteoclast act on the bone and they like shape it or something like that. Like excess is removed,
yeah, it's the balance between osteoblast, which forms
blast
the
and
new
yeah.
bone cells, and then the old bone cells are taken care by osteoclastic cells.
Sorry. So ask you another question. What is osteoblast? What happens in osteoblast and what happens in osteoclast? Who will break? Who
Sir,
will form?
So the
Osteoblast will help in formation of
osteoblast will
new
break.
bone cells, and osteoclast will cause the old cells
sir,
to.
osteoblast is mineralization of the bone, and osteoclast is demineralization of the bone, sir.
Mhm. Interesting. A lot of definition, you see. Yes. Anyone? Fine. So this is basic. You go, everyone, this is homework. You see, you go and read it, osteoblast, osteoclast. We'll discuss here only as well. So now let's jump to the answer. Yes, Dr. Saleh, what do you think? What is the answer for this question? Now forget about bone resorption. We'll discuss it as well in next 1 minute. But now look at the answer. What things? What is the answer
It
for
is
this?
I think option B, teriparatide.
Okay, so now tell me what is teriparatide? Which group of drug? What is the primary action? Or something related with one liner if you can know what is teriparatide. Like say for example, metoprolol. It's a beta blocker drug. It reduces the hypertension, antihypertensive, anti-anginal, anti-arrhythmic drug, right? It blocks the AV node, reduces the conduction, reduces the heart rate, blah blah blah. Right? So what is teriparatide?
Sir, it's a synthetic
Thyroid hormone.
No,
parathyroid
let,
hormone.
1 minute, doctor. 1 minute, 1 minute. Let her answer. I'm not in hurry. If I will take 3 hours class today, don't worry. I'm not hungry. Saleha, you tell me first.
I don't remember which group it belongs to, but I said because it's given in post-menopausal women to take care of the osteoporosis which they go through.
Okay, fine, fair enough. So let me tell you, teriparatide is, remember, recombinant human parathyroid hormone, exactly 134, right? It is a anabolic. These all are the keyword. Anabolic agent, anabolic agent. Shortly, I can say bone building, bone building. It builds the bone, right?
Yes,
So
agree.
when people are going to gym, they wants to make a nice bicep and tricep and muscle. They are taking anabolic steroid just to strengthen the bone, body building, bone building, right? So this is the things, right? So what is teriparatide? Teriparatide is a recombinant human parathyroid hormone. Is that clear? And what is the main acts on, right? So it acts as an anabolic agent or bone building agent, right? What are the indication of this teriparatide? So teriparatide is used for the post-menopausal woman, right? With risk of high fracture. So those patient who has a high risk fracture, how do you know high risk fracture? Look at the T score. How you get the T score? The DEXA scan, right? T score anything less than or equal to 2.5 of T score, it is called as osteoporosis. There is a question in next coming up slide. So say for example, I did it for my mother. She is 80, example, right? I'm thinking, oh, she may not develop the fracture. She is 18, post-menopausal. Let me go and do the T scan, DEXA scan. I seen DEXA scan, so -3, high risk of fracture. I use the teriparatide. Is that clear? Yes or no? Why? Because
Okay.
it is used for severe osteoporosis, which strengthen the bone and reduce the risk of fracture. Is that clear, Dr. Saleha? Yes or no?
Yes, doctor, very much.
It is also used for the last renal transplant and steroid patient. This is official indication as per the standard international blue. So this is one indication. Second indication also use men with osteoporosis, not only female. So men and female both 1 and 2. Third is a glucocorticoid induced or steroid induced osteoporosis. So those patients who are on steroid for long term, right, they are risk of fracture or avascular necrosis, you can give them, right? And also, last but not the least, as per the book, fourth indication, those patients who cannot tolerate bisphosphonate or denosumab, this also bone strengthening agent. If they are contraindicated because of renal insufficiency or because of any reason, either it is contraindicated or they cannot tolerate this drug, teriparatide is the treatment of choice. 20 milligrams subcutaneously given once a day daily, right? And up to 2 years, you can give to this patient as per the safety profile given in the book. Is that clear to everyone? Yes or no?
Yes, sir.
Yes.
Wonderful. Wonderful. So let's see basic definition. Bone resorption is the process, right? Is the process, right, by which the bone is broken down. So this is process. Bone resorption is a bone broken down process. Process by which bone broken down and it mineralize and it's mineral. When bone broken, right? When bone broken, what happens? The minerals, mainly the calcium and the phosphorus, are released into the blood. So they are in the bone, calcium and phosphorus in the bone. But when bone gets fractured or broken down, it releases in the blood. So hypercalcemia and hyperphosphatemia may happen. So any fracture, right? They may happen, right? Then it may happen. right? So calcium and phosphorus may releases into the blood. So bone resorption is a process by which bone is broken down and its mineral means bones mineral like calcium and phosphorus are released into the bloodstream. Is that clear to everyone? Yes or no?
Yes, sir.
Yes,
Wonderful, wonderful. So this is the basic concept which we need to know, right? What is the other thing, right? So key points about the bone resorption. Who performs bone resorption? Who performs bone resorption? Right? When, right? So osteoclast, large multinucleated bone destroying cell, right? So this is the thing is. And what regulates the bone resorption? What regulates? Is there any regulatory mechanism in our body which regulates the bone resorption? So answer is yes. Hormone increases osteoclast activity, means parathyroid hormone increase resorption, means it's not good, right? It's not good. Vitamin D increases the calcium release, thyroid and rankle pathway, so you don't need to very much stress about this. Decrease resorption, calcitonin and estrogen, right? So if you give the calcitonin, it's good. Estrogen, it resolves. Why postmenopausal woman lose bone, right? So this is the things which you need to know. Condition that increase the bone resorption means, right, bone breakdown means calcium phosphorus release in the blood. So what are that things which increase the bone resorption? Osteoporosis, yes. Hyperparathyroidism, yes. Prolonged immobilization, yes. Inflammatory cytokine, yes. Steroid, yes. So these are the risk factor for bone resorption. So all increases the bone resorption. Our question is all of the following increases the bone resorption except. So our question was except, and except is teriparatide, right? So this is what the answer is. So rest of the all other options are this thing. So let's see head to head comparison for better clarity, right? So I love the comparison. Without comparison, how did we get to know, right? So our answer is a, right, which accept. So accept teriparatide. This is the answer for our question. Res, Resindronate, it's a class of bisphosphonate drug. It inhibits the osteoclast mediated bone resorption. It reduces the bone resorption. So everybody is reduces the bone resorption except, so except is teriparatide. It does not reduces the bone resorption. It increases the bone formation. That's it. Is that clear to everyone? Yes or no?
Yes, sir. It was clear.
Saleha, is that clear to you?
Yes, sir.
Yes, sir,
Yes,
clear.
sir.
Wonderful. Wonderful. So we need to understand the basic. Once we understand the basic, the job would be easy for us. Yes, let's jump to the next question. Radial now we discuss. So we are not going to discuss. Again, a basic, very important and easy questions too. An elderly female presented with history of bilateral hand stiffness that is worse in the morning. On examination, she had a bony swelling in a distal interphalangeal joint. These swellings are what? You describe this swelling as a Haberden nodule. You describe this swelling as a Bouchard's nodule. You describe this as a synovial thickening, or you describe it as a synovial cyst. So before jumping to the answer, if you keep this basic in mind, what is the diagnosis? Then your job
Diagnosis
would be
is
easy.
rheumatoid arthritis.
Then investigation, then treatment.
Sir, the diagnosis is osteoarthritis. And the
Wonderful. So
answer is A.
one answer is osteoarthritis. One differential diagnosis is rheumatoid. So
Rheumatoid
those who
arthritis.
answered me, Indu, tell me
Yes.
what point favoring the rheumatoid arthritis first of all. Then I'll
Sir,
listen from you.
sir, in rheumatoid arthritis, in morning there will be having a pain, but in osteoarthritis, pain will be having after any work, like any
Okay, so let me write down here. Morning stiffness is increase
yes,
in rheumatoid arthritis, right? This is a evening stiffness. This is morning stiffness, evening. So they are saying worse in the morning. So 1 point may be favor. Okay, fine, no problem. We'll discuss. We'll dissect. Do you think rheumatoid arthritis is developed in an elderly female? By my knowledge, this
No,
develop
sir.
usually in 30 to 50 or
In,
20 to 40, usually, right? Elderly female, do you think it happens?
no, sir. When osteoarthritis will happen.
Fair enough. Those who answered me, Indu, I'm telling especially for you. So,
Yes, sir.
morning stiffness can be in rheumatoid arthritis, 100% correct. Probably this is a disease of young female, not the elderly female. Do you
Okay.
think, Dr. Indu, that there is a distal interphalangeal joint swelling is there in rheumatoid arthritis? Distal
Uh,
interphalangeal joint is there in rheumatoid arthritis? Yes or no?
yes, sir. Actually, we have.
Is it developing? So now tell me, Dr. Indu, in osteoarthritis and in rheumatoid arthritis, right?
Hmm.
What joint involves? Commonly, what joint involves? This and this. Tell me. Lots of question
Osteo
with this.
Osteoarthritis, knee joints are mostly involved, sir.
Knee joint involved. Okay, here which joint involved? Rheumatoid arthritis.
Like phalangeal joints, sir.
Phalangeal joint. So our scenario as phalangeal joint. Okay, fine.
Yes, sir.
If I can ask you five, six question, proximal interphalangeal joint, distal interphalangeal joint, metacarpophalangeal joint. What is more commonly involved here and what is more commonly involved here?
Sir,
Options are same in both.
in
Yeah,
rheumatoid
rheumatoid, you
arthritis, proximal and distal interphalangeal joints are involved, sir.
proximal interphalangeal and distal interphalangeal joint. And here,
Yes, sir. I don't know, sir.
sorry,
Sorry, I don't know, sir. Like,
fair
I'm not
enough.
sure.
You have to completely read whole chapter of osteoarthritis and rheumatoid arthritis and tell me in the evening.
Osteoarthritis knee
Sure,
Deadline
sir.
is
joint.
evening.
Yes, sir. Sure, sir.
Wonderful. Sorry to give you the homework. Don't feel
No, sure, sir.
bad about
It's
me.
okay. No, sir.
Yes. Anyone wants to make any comment? What is the final answer? Dr. Rabia, have you seen such patients in your OPD, IPD, or any cardiology OPD? Some patients coming with the joint pain and all blah blah.
Yes, sir. This is answer is osteoarthritis. I'm going to favor of osteoarthritis.
Wonderful. So in osteoarthritis, amongst A, B, C, D, what you see in your, I mean, by your knowledge, what is that?
It's should be C.
It should be C, synovial thickening.
Yeah.
Okay.
Sir,
So
both A and B are seen in osteoarthritis. In this case, it is a Heberden nodule in the distal interphalangeal joint.
where
And
you see the
proximal,
bulge,
it will be Butcher.
fine. So
Butcher's
where,
nodules in the proximal interphalangeal joint
fair
and
enough. So where
Heberden
you,
in distal.
wonderful. So where you see, in which condition you see the Bouchard's nodule? Can you tell me the name of the disease where you see Bouchard's nodule?
So Butchart nodules and Heberden both are seen in osteoarthritis. OA.
Osteoarthritis or rheumatoid arthritis, sorry. We have seen
Osteoarthritis,
many,
it's
we have seen
Both are
thousands of
seen in
times.
osteoarthritis.
Wonderful. Fine. So now
both
let's
are
jump.
seen.
Wonderful. So now listen me for 1 minute. Everything is clear. But you see how simple questions still making confusion in our mind. So answer is Hubbard nodule. Let's dissect what is Hubbard nodule. So let me show you one brilliant picture. I think you must have also seen, not just me alone. So this picture, I love this picture. Just to have a more clarity. What happens to my internet? Yes. Just basic distal interphalangeal is where, proximal interphalangeal is where, metacarpophalangeal is where, carpometacarpal, carpal bone. This is carpal and this is metacarpal. And this is interphalangeal. So first we need to understand where is what term is used for what. So now I think it's very transparent, clear cut. right? I had given you excellent, brilliant X-ray of the bones, distal interphalangeal, then proximal interphalangeal, metacarpophalangeal, interphalangeal, carpometacarpal. Is that clear? Yes or no? At least this yes or no. Until and unless we know this, how do we get to know where is distal, where is proximal, blah, blah, blah. So now see, this is a beautiful picture here. This picture here is a distal, is a Haberden, proximal is a Bouchard. Is that clear to everyone? This is again a brilliant picture, right? Now just go to the literature now. Haberden nodule, bony swelling is in the distal interphalangeal joint. This is a classical for osteoarthritis, particularly the Haberden's nodule. Now let's dissect more. Type of the nodules in osteoarthritis. There are two types. One is Haberden nodule, one is a Bouchard's nodule. So what is Haberden nodules? So Haberden nodules is seen in a distal interphalangeal joint. Bouchard is usually seen in a proximal interphalangeal joint. Haberden is a bony outgrowth or osteophyte at distal phalangeal. This is bony outgrowth at proximal interphalangeal joint. Any doubts so far? Comment. House is silent.
No,
Dr.
doctor, it's clear.
Rabia, Dr. Saleha, Saniba, Anisha, Indu, any comment?
No,
I
sir,
think
it's clear.
Clear,
that's
sir.
Wonderful, wonderful. Let's dissect osteoarthritis versus rheumatoid arthritis. Dissection. Dissection means head-to-head comparison. That is dissection. So our patient is elderly. Rheumatoid arthritis is usually and until proved otherwise female. Autoimmune disease. This is not at all a autoimmune disease. Don't confuse between osteoarthritis and osteomyelitis. Don't confuse. Osteoarthritis is aging process. It is a degenerative disease. It is a wearing and tearing of joint. More you use the joint, earlier you develop the osteoarthritis. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Joint involvement, distal interphalangeal, here proximal, never ever or rarely involved by literature, not involved. What not involved? Distal interphalangeal joint is not involved in rheumatoid arthritis. Proximal, metacarpophalangeal, wrist joint. I showed you the picture before starting my talk. So now you need to, where is the proximal interphalangeal? Where is the distal? Where is metacarpophalangeal? Interphalangeal joint, blah, blah, blah. Bony hard. Swelling is bony hard. Haberden. This is soft. In rheumatoid arthritis, it is soft. Morning stiffness less than 30 minutes, here prolonged morning stiffness. So here somebody given the answer rheumatoid arthritis, they confuse here. Why? Because in first line they had given morning stiffness, and that is why you, right? But elderly not favoring, distal interphalangeal not favoring, so you miss to see that part. You just stick to the morning stiffness. So what is the bottom line of the things? Read the question well. Out of 100 seconds, spend 95 seconds in reading the question, 5 for interpretation second, and tick the answer. Just so 95% time should be sent. It's a secret of success I'm sharing with you. I also cracked 10 exam in various countries. So I'm just trying to share my experience. I'm not here to teach you. You all are brilliant, but I'm trying to make your concept bit better. Systemic features are none, right? Systemic features are none, often present. What do you mean by sir systemic feature? Fever is present, weight loss is there, extra articular involvement is there, ANA is positive, right? Rheumatoid arthritis, NTCCP is most sensitive and specific, ESR is high, blah blah blah. Here nothing. Only do the joint x-ray of knee joint, reduce the space, osteophytes, and sometimes cyst. That's it. This is what in x-ray of this. Here you can all see. You never ever get a fever here. You never ever get a weight loss here. You never ever get some constitutional symptoms here. Nothing. You never ever see ANA positive, anti-CCD positive, RA factor positive, all negative. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful.
Yes, sir.
Brilliant. These all are all high yield questions. All high yield questions. Let's jump to the question number 19. Patient with the scoliosis. Scoliosis. You must be knowing scoliosis, right? Let me show you the picture of scoliosis. This is scoliosis. I love pictures, so I have lots of picture in my presentation. This is a nice spine, straight spine. This spine is distorted. Scoliosis. This is scoliosis. Now let's go back to the question. This is scoliosis. Just for clarity, what is scoliosis? So patient with the scoliosis, you need to refer him to orthopedic at what degree of scoliosis. So there is a classification, right? It is called as a right cons classification. So not going much in detail of that classification, blah blah blah. Very high yield questions asked many times in exam, right? Ortho rheumatoid. So this scoliosis, right? So patient with scoliosis already. This is a normal spine. This is a scoliotic spine. So you need to refer him to orthopedic. At what degree you refer to orthopedic? A case of scoliosis at what degree? If the scoliosis is less than 10 degree scoliosis, you refer 10 to 20 degree you refer, 20 to 40 degree you refer, more than 40 degree you refer. What also I need to know what is the severity of scoliosis. How you supposed to treat as per the severity. If somebody has 5% scoliosis, 10%, 40%, how you treat them? Yes, anyone, open. First think the answer, then think the what is the severity, how you treat. Yes, anyone. Those who are working in orthopedic, they may probably know. Though I'm a hematologist, but I know, so you must know. I'm not appearing for exam. You are appearing for exam. Yes, Nisalal PB, Chris Susan, Fatima, Nasira. Speak up. Little bit speak up. Don't worry. Right or wrong is not an issue at all. Don't worry. Speaking up is important, not the right wrong. Yes. Anyone?
So
Did I
10
ask
to
very
20
difficult question?
degrees.
50 maybe more.
Okay. 10 to 20 degree. Okay. So one
Like
answer
more
is
than 10 is scoliosis.
sorry, doctor. What's your name? Sorry, I cannot. Let me check. 1 second.
Deepika.
Dr. Nisha. Yes, tell me if you are speaking. Tell me. Yeah, sorry.
Yes, maybe 10 to 20 degree.
So this is guess or you know?
So more than 10, it is scoliosis is what I know. So basically, if you have to refer to orthopedicians, it should be more than that. So minimum 10 to 20.
Minimum 10 to 20. So what you do if they have less than 10? So 9%, if they have 9%, what you do? Say for example,
Eh,
right? Question is that patient with scoliosis of 9%. How you treat? Second question. Tell me, Deepika. You need to do something for scoliosis. No? You can't say, oh, no, don't worry, 9%, you go ahead.
We can
10%, I'll refer you. 9%, won't do anything.
I think
we can go for braces.
Yes,
Is
Rabia.
a conservative treatment.
Yeah,
Sorry?
I think conservative is better for
Conservative.
Conservative
Wonderful,
treatment.
wonderful, wonderful, wonderful. Conservative, wonderful. What is 10 to 20? What is the treatment? What is more than 20? What is the treatment? Anybody, open for all. Fine. So let's go to the literature. Without literature, we can't understand anything. So Cobb's angle, this is Cobb's angle. Some gentlemen probably innovated Cobb's angle used to measure. Cobb's angle used to measure what they wants to measure the degree of spinal curvature on which modality? It's X-ray. So Cobb's angle is used to measure the degree of spinal curvature. What is spinal curvature? This is spinal curvature, right? How they supposed to do? By X-ray. Just for your knowledge. So what is Cobb's angle? So Cobb's angle is used to measure the degree of spinal curvature on X-ray. So Cobb's angle is less than 10%. Posture is asymmetrical, obviously, right? It's not a true scoliosis. You just observe it. You observe it. You don't need to do very much aggressive and open up the whole spinal cord and spinal cord plasty and all. Doesn't require 10 to 20%. Mild scoliosis refer to orthopedic, and our question is at what angle you refer to orthopedic. So answer is 10 to 20%. This is the answer for our question. 20 to 40%. Moderate scoliosis considered bracing, especially in growing child. More than 40 to 50%, you have no other options. It is a super severe scoliosis. Except surgical evaluation or operation, nothing will cure this patient. Is that clear to everyone?
Yes, sir.
Yes or no? So scoliosis is defined as a spinal curvature of more than 10% Cobb angle, less than a 10%. We have nothing to do. Key clinical points: Cobb angles is used in X-ray evaluation, used to monitor the Cobb progression, right? So simple. Cob is equal to curve of backbone. Cob means curve of backbone. And this is the little understanding for you. Brilliant picture. I got it during my research on this PowerPoint. So this is normal, less than 10%. No need of any treatment. Observation. Here 10 to 20%. It is a mild, right, where you need orthopedic reference. You cannot observe. Do something. This is moderate, 20 to 40%. This is severe, right? Here you can do some bracing, try to improve the posture, try to strengthen the spinal cord, which is distorted. And here, none other than surgery, operative intervention. Is that clear to everyone? Dr. Saleha, I think it's clear to you. Dr. Purnima, Anisha.
Yes, sir. Clear.
Wonderful. So don't forget, though it is a easy questions, but frequently asked questions in the exam. So this is a basic point I just mentioned you how we supposed to go about it. So let's jump to the next questions. Patient has a urethritis. Patient also have a knee pain, left knee pain. Patient also have a conjunctivitis. Urethral swab positive for pus cells, but negative for Neisseria meningitidis and chlamydia. What is the most likely diagnosis? Is it rheumatoid arthritis because of pain in our all blah blah? Is it Ritter's disease? It is septic arthritis because patient has something in the pus in the urine and now joint pain, so probably septic arthritis, or it could be an infective arthritis, osteoarthritis. Patient has a yes.
Writer's disease, sir.
Related disease.
Writers.
Okay, wonderful. So everybody is writers. Who is not writers? Just tell me. That's it. But it does not agree. They can say, huh? Don't. Nobody will write the paper on behalf of you. You have to give your own answer. If 100% say writer's disease, but if you are not agreed, you can tell. Yes, anybody? Yes, Indu. What's your answer?
Sir, writer's disease, sir.
Okay. Is there any name
Pediatric.
for Ritter's disease? Is there any other name of Ritter's disease?
Reader syndrome.
If I can give you here options, reactive disease. Have you heard of this word, reactive disease?
Reactive arthritis.
Sorry? Can anyone have heard of reactive disease?
Reactive
Same
arthritis.
as rhinitis.
So what is a reactive disease? So fair enough, this is clear-cut triad of Ritter's disease. So let me tell you the things. Ritter's disease is equal to a reactive disease. So there is a no two different name. Now people call this as a reactive disease or reactive arthritis. Triad, cannot see means problem in the vision. Cannot pee, C and P means cannot urinate or difficult in urination. Cannot climb because of arthritis. So simple, three line. Cannot see, cannot pee, cannot climb. Cannot see. Cannot see means conjunctivitis, eye involvement. Cannot pee means something wrong in the urethra, sterile urethritis. Why? Most important is sterile urethritis. Why? Because no gonorrhea, no chlamydia on culture. So you did not get the culture positive organism, but still there is a urethritis and cannot climb, right? So cannot see, cannot pee, cannot climb, that is arthritis, cannot climb a tree, typically asymmetrical joint, knee or ankle involvement. So if you have this triad, urethritis, conjunctivitis, arthritis, it is Ritter's or reactive arthritis. Let's go back to the question. This is the question, right? So this is a question, right? Urethritis cannot be, knee pain cannot climb, conjunctivitis cannot see, cannot be, cannot see, cannot climb, right? Negative, sterile, right? Urethritis, urethral swab, pus cells, but negative for this, right? So anyway, so this is why not rheumatoid arthritis, because in let me give you the comparison as usual, so that makes your life and job easy. In one slide everything is clear cut. Rheumatoid arthritis, symmetrical, small joints involvement, proximal interphalangeal joint involvement. Septic arthritis, purulent joint infection. We do not have. Culture positive. Our culture chlamydia is negative. Infected osteoarthritis occurs in a pre-existing arthritis joint. So summary is sterile urethritis with no culture positive, arthritis, conjunctivitis. This triad is Ritter's or reactive arthritis. Culture negative makes infections unlikely. That is why it is not infected osteoarthritis. Any doubt, any questions, comment, suggestion? Is that clear? Yes or no?
Yes,
Yes,
sir.
sir.
Wonderful. Fine, let me discuss couple of more questions. I'm speaking with my full energy for last 90 minutes. Very quick question. Female came complaining of photosensitivity, malar, rash, joint pain, had RBC in the urine. What is the diagnosis? Rheumatoid arthritis, lupus nephritis, gout or SLE?
SLE.
Why? And why?
SL
Malar rash,
Let's
butterfly rashes suppression.
is the butterfly
so
rash on chicks.
So can anyone tell me why not it is lupus nephritis? Because patient has RBCs in the urine and all blah blah. Why not? Okay, fine. I'm agreed. It is SLE.
Other
But I'm
symptoms are
asking one
also there,
question.
so we need to consider it as the entire syndrome instead of particular
Yes.
thing.
So it is lupus nephritis or SLE?
I said
Yes, Purnima. Deepika.
SLE.
SLE. Wonderful. Brilliant. It is SLE. Don't worry. I'm happy you stick to your answer. Do the same thing in exam. Don't deviate from your real answer. Yes. So correct answer is SLE. Key features, explanation for SLE. Photosensitivity. It is there in our scenario. We have photosensitivity. Malar rash, yes, butterfly rash. So this is a face of the patient. This is neck and this is nose, but there is a butterfly rash on the cheek, like a butterfly. Just for you. So you see some picture. I forgot to add the picture, but next time I'll make sure I'll add this. So there is a butterfly rash, joint pain, RBC in urine. Why RBC in urine? Because of SLE, kidneys are involved. That is why renal involvement. So this pictures together classical SLE. It's an autoimmune connective disorder. It's a multi-system autoimmune disease characterized by production of autoantibody against nuclear antigen. Is that clear?
Yes.
Wonderful. Fine. So let's me conclude the talk with this why not. My lovely topic is why not, because we have four options. We told that sir it is SLE, but why not gout? Why not lupus? Why not RA? So let's see why not. So lupus nephritis is a complication or subtype of SLE. It is not a primary diagnosis. SLE do lupus nephritis, not the primary diagnosis in this case. So rheumatoid arthritis joint involvement only, no rash, no photosensitivity, right? No RBC in the urine. Lupus nephritis, renal manifestation of SLE. It is not a primary disease, right? Gout is a monoarticular, usually big toe, no photosensitivity, uric acid is increased, which is not mentioned here. SLE fits all finding, rash, photosensitivity, arthritis, and when SLE involves kidneys, there is a RBC in the urine. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful. Would you like to take me one more questions or I'll end up?
Mm. No, sir, we'll take another one question.
Wonderful, brilliant. Because few people looks like hungry. They are not talking and speaking.
No,
Sorry.
sir.
But
So before they get hypoglycemic attack, I should stop. Otherwise, I will be the culprit. Best marker of drug-induced lupus. Best marker. Antihistone antibody, anti-DSDN antibody, anti-neutrophilic antibody, anti-Smith antibody. So whatever your answer is, I need to get four more questions. If it is positive, what is the diagnosis? If it is positive, what is the diagnosis? If it is positive, what is the diagnosis? And if this is positive, what is the diagnosis? So first of all, get one answer.
anti-histone antibodies.
Wonderful. Antihistone, that is the answer. Antihistone antibodies is seen in drug-induced lupus. Now tell me, Dr. Indu, what where the anti-dsDNA positive? If I have a anti-dsDNA positive, what is the diagnosis? Anyone? Open for all.
Oh,
Yes, Dr. Saleha, if you are in
yes,
the talk still, what do you think? What could be the answer?
yes, only.
Yes, please. Yes, Dr. Anisha, would you like to speak something?
Yeah, this NTDS DNA is SLE.
Okay, this
Okay.
is SLE. Then what is anti-neutrophil antibody? What's the diagnosis? So we need to know each and every antibody. This four, then this is anti-CCP. Write down anti-CCP, ANK, PNK, right? Anti-Ra, anti-Rho, anti-LA, anti-phospholipid, antibody. This write down. Take a picture. They will ask you these questions where good pasture what present, this Wagner's what's present, neonatal lupus what present, right? Antiphospholipid antibody, recurrent miscarriage, blah blah. There are a lot of things we probably discuss in hematology, but this is what you need to know, each and everything. At least one liner. If this positive, this is the answer. If this positive, this is the answer. So you need to go and make a list. I have a list on our website. So in Ortho Rhumato, you can check it out. But for the sake of the answer, I'm closing my talk with this. So antihistone antibody. Can anyone tell me which drug? What was the question? So best marker for uh, drug induced lupus. So drug induced lupus answer is antihistone. I want to know the drug. Can anyone tell me four or five drug name which can cause which drugs giving by this drug they can cause the drug induced lupus where the antihistone antibody is positive. So can anyone tell me the name of the drug? It's a clinical, na? While you are giving the patient the drug, you must know what drug. So let me tell you the drug because this is probably you may not much in detail of that drug. So these are the commonest one. There are a long list of drug, but these are the common which people are using in day-to-day practice in their practice, and probably our parents are taking this drug. Antihypertensive hydralazine, anti arrhythmic procainamide, antituberculous isoniazid, anticonvulsant phenytoin, other markers there. So if you don't remember this, that's fine. But these are the very common. So almost many patients globally taking this drug, procainamide, INH, each and everybody, tuberculous patient, INH, rifampicin, pyrazinamide, ethambutol. So INH is the cornerstone of the AKT. Finite on any anticonvulsant, it's there. Procainamide, ventricular tachycardia, ventricular VT, procainamide, PAM, procainamide, amiodarone, lidocaine, and magnesium sulfate. These four are the drug of choice. One of them is procainamide. Pregnant and non-pregnant, moderate to severe hypertension, crisis, urgency, emergency. We use hydralazine. So anyway, this is what from my side. Thank you very much. I end up my sessions. Before I end up my session, I would like to have just one more minute from you guys. How did you enjoy something new, learning, blah blah? What's the thought process? Did you learn something new from my talk or not? Yes, please. That probably helps me to improve my system and myself per se. How I can deliver the better lecture than this? That is why I'm asking. Yes, please.
Well, sir, as today is my first day, I really appreciate you.
Wonderful.
That's a
How did you enjoy, Dr. Rabia, your class? I mean, what was your thought process before joining, and what is there? Did my class
yeah.
make some changes in your thought process? That is more important rather than just reading, reading, reading.
I remember one of my professor in my student life. He always asked why not. So I really appreciate it.
Sir,
Wonderful.
It's
diagrammatic
made
representation always stays in the memory for long. So that is very excellent way of explanation, sir.
Wonderful.
actually.
Brilliant. Thank you very much for your kind feedback. I am also learning medicine at the end of 25 years of my practice. So, anyway, we learn together. Thank you very much for your feedback.
Thank you so much, sir. Thank you so much for all
Thank you, sir.
Wonderful. No
explanations.
Thank you
problem.
very much.
No, no problem. Anyone else had something new click in their minds, something new learned, or they feel that they need to change the way of they are preparing for themselves? So, I mean, see, we are a doctors, I mean, right? So, those who are like little away from the practice, away from the academics, not open up the book for 5, 10 years, they are in practice and now willing to go to Middle East. I think you join the coaching. I'm see the one lecture makes huge difference. So see, if you see 30, 40 lectures, then your 90% course is covered. This is
Yes, sir.
all about the thinking how you think. We knows everything. I have no doubt that you don't know anything. You knows absolutely thing, but being by my experience coaching and delivering thousands of lecture in last 20 years, I'm just trying to give you the concept how you supposed to prepare. right? How you supposed to think, how you supposed to interpret and dissect the MCQs. Otherwise, we knows everything. I mean, everybody knows rheumatoid arthritis. But when it comes into the MCQ format, what is important, what is not important, what needs to be more important in the questions, how to exclude ABC, the way we are doing in every question, that brings more clarity by my sense, isn't it?
Yes, sir.
Yes, anyone last but not the least, anybody wants to have last comment? Dr. Chris, Susan, I think
Uh,
I did not heard you. Yes, please. Yes, Anisha.
yes, sir. It is a wonderful lecture and many concept clear. And especially this making charts and pictures, it makes very easy to understand for me, and it will help in my cracking the exam. Yes.
Wonderful, wonderful, wonderful. I just need to see you are pass in group. That's it. Great, wonderful. Yes, Dr. Chris, I think you joined first time, Chris Susan, or I'm seeing you first time. I don't know.
Hello, sir. I've listened to one class long back. Um, After that, I'm just joining now. And
Mm-hmm.
the session was very nice. I've watched your YouTube videos. So I know, like, I've been set for a class live session, but I've seen your videos. So it was very helpful for me. And I thought, although we solved a few questions, but there were so many things I covered in just one session. So that was very,
Wonderful,
like, it
wonderful.
was
So
very,
don't miss out.
yeah, sir. Thank you,
Wonderful.
sir.
Don't miss out next time. Yes, Doctor. Deepika, any comment last?
Sir, I have to ask you a question.
Yes, please.
How come you are so patient, sir? So calm and patient.
It's a
Means what
practice.
is the technique we should do?
Practice, practice. Listen, I'm a good listener. So listen. I listen in OPD every day. I have seen registered, to be honest, more than 200,000 patients since 1998. Registered patient. So I listen each and every patient coolly and calmly. What exactly they wants to tell me in front of me. I'm not orthopedician. I'm a hardcore hemato-oncologist and bone marrow transplant fellow. So I listen. By listening, in 10 minutes, I make a diagnosis. I'm not praising myself. They are the people who can tell you what exactly going on. I ask few tests. Okay, you do CBC, peripheral smear, LDH, B12, folate, blah, 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 evening bone marrow, next day diagnosis. That's it. So try to cultivate the practice, listen the patient, right? Try to do maximum MCQ, try to do maximum mock test and check your score. What we are practicing, we are reading. Somebody saying me, I am reading sir 10 hours, but I got failed. No need to read 10 hours. No need to read 10 hours. It's a wrong practice, believe me. Read 4 hours, but that 4 hours should be absolutely quality. My room is closed. Nobody can enter in my room at my home. Even my wife, my kids, nobody enter. I am concentrating on MCQ means MCQ for 1.5 hours. Nobody in this world will disturb me now. That could be the reason probably why I can able to deliver better lecture day by day. So I do lots of exercise. Believe me, I'm not praising again. I need to do lots of hard works to compile all the slide, make it in a reasonable way, and I'm not taking any help from any expert or professional. I do by my own. So I will start my next Sunday's planning from today only. So I'm not just like, oh, relax now. I have 1 week, 12 to 1:30 next week. I start preparing slide from today only for the next Sunday. So next Sunday I will not get any stress. Okay, fine. Anytime you can tell me, I can deliver you lecture on any topic, any subject. You decide. I will open up my computer. Everything is ready. I can present. It's a pre-plan. It's a organized work. It's a disciplined work. If we learn this, I mean, don't take it otherwise. I'm not advising you. You all are respected for me, but I'm sharing my experience, right? So I mean, prepare well, basically,
No, sir.
right? Try to do the
No, sir. I
practice.
appreciate that because no, I appreciate what you are saying, sir, because it's a tried and tested thing. Whatever you are
Yeah,
doing, it has given results.
It's the
Yeah,
result of the
so
hard work.
no, I always wish for everybody's success, doctor. No company in this world who can take this lecture. No company in this world. If you get any company who is taking hundreds of lecture at no cost with full 100% effort, my goal is to give the
Yes,
proper education to the people, and they should know the what is the real right things. That is the goal. That is why this
yes,
company was started. Believe me, little out of the box talk, but this is main thing is the things, right? Though probably we may have some mistakes, some tricks and on website, but we are improving. See, we are improving. So I'm not saying I'm
yes,
100% or companies 100%, blah blah blah, but none other than us is so sincere to deliver this study material, book, website, coaching, answer, blah, 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 whatever you say, right? Because we are a
yes,
doctor. I know your field. 90% people, what they are interested. Oh, 3 महीने का subscription ले लो हो गया. They are disappear. Absolutely out of the planet. You cannot trace them. Believe me, anybody can trace me. Anybody can trace me. Anybody can. I'm so busy, so approachable. So busy, so
yes,
approachable. It's not small thing.
yes, yes,
Anyway, when you are at my level after 25 years of practice, this looks boring, but it's a passion for me. Coaching is passion for me, right? So that's fine. I'm
yes,
enjoying. So hopefully you are also enjoying because I'm enjoying. The day I'm not enjoying the coaching, you will not enjoy. That is what I believe.
yes, sir. Thank you very much.
Wonderful. So
Thank you
best
so
of
much,
luck,
sir. Thank you.
everybody. Keep in touch, right? And stay tuned. We'll see you next week. Meanwhile, those who
Thank
are
you, sir.
not in coaching, think of coaching. Do let me know if you need any help, personal, physical, financial. Don't worry. It's not all about money. It's all about the success. So if anybody needs personal level help, feel free to call me. We'll do it. Thank you very much. Enjoy your Sunday.